My name is Dr. Ari Smith, Pulmonary Critical Care. I just want to share with you some observations over the past week or so, 15 or so, very sick ICU patients in the ICU. Just a note about COVID pneumonia management, ventilator or non-ventilator dependent. I find that patients with higher oxygenation typically do better, meaning we have this concept in ARDS, at least, permissive hypoxemia is better. And also dry lungs better than wet lungs. In this disease, it seems a lot more like acute chest syndrome and sickle cell disease, where they do a little better hydrated and they do better when their oxygen is actually not permissively let lower. So the concept is that even in early disease, where we allow patients to sort of struggle at home, maybe with a saturation of 93%. I personally don't think that's the right approach. I think that if we could give them oxygen and get their numbers higher, it might actually prevent the microvascular thrombosis, and it might prevent some of the worsening hypoxemia and cytokine storm, perhaps. I found it in a lot of the patients early on also, that if we allowed them a higher oxygenation, even pumping up the non-rebreather mask and a high flow nasal cannula, and not necessarily allowing or being happy with the 91% saturation on 6 liters nasal cannula, I think that is perhaps a smart approach. I'm open to hear other people's experiences and opinions. That's just my little opinion there. Thanks.